Okay. Hello, everybody, and welcome to Grand Rounds. Today, we have the pleasure to have Dr. Robert Soiffer. He graduated from New York University School of Medicine in 1983 and trained in internal medicine at Brigham and Women's Hospital, where he was also a chief medical resident. Then he joined the DFCI in 1988 after completing a medical oncology fellowship. He's currently the Division of the Chief of Hematologic Malignancies and co-director of the Adult Stem Cell Transplantation Program. He is the chairman of the Center for International Blood and Marrow Transplant Research Advisory Committee and had served as vice president in 2006, president 2007, and immediate past president 2008 of the American Society of Blood and Marrow Transplantation. Today, we are delighted to have you with improving the outcomes of allogeneic hematopoietic stem cell transplantation. Dr. Soiffer, thank you very much for being here. You can go ahead.
Thanks very much for that very kind introduction. I'm so pleased to be here, or virtually here. I have many friends in Miami, and I want to particularly reach out to Krishna Kamanduri, who has been a colleague for many years, and Steve Neimer, of course, who I've known for many, many years. And I'm delighted and proud that my daughter, Jenny, is in the audience as a fourth-year medical student. So I've had a lot of time to be down in Miami, and unfortunately, I haven't been down there in a while because of this dreadful pandemic. So I'm going to talk to you today about improving the outcomes of allogeneic hematopoietic stem cell transplantation. And I'm trying to move my, there we go. And these are my disclosures. I'll leave for a second. So bone marrow transplant or stem cell transplant dates back a long period of time. And here are some highlights that I just want to mention. You can see over here this intramedullary sternal transfusion of human bone marrow. That was first reported in 1940. And that was actually a situation where a young child had sternal bone marrow removed from his brother and placed into him. That was done at the hospital that I was born in Brooklyn. At Brooklyn Jewish Hospital, and they supposedly cured this patient. I'm not sure if that's true, but it was the beginning of transplantation. And you can see over here in animal studies by Barnes and Lutti, introduction of homologous marrow in 1956 was able to actually restore hematopoiesis and destroy tumor cells. That was the first time that was identified. And then in 1959, Don Thomas, a Nobel Prize winner, had his remarkable first observations of human transplantation. And you can see down here at the bottom, in 1963, Mathe et al. Was able to describe what was called secondary syndrome, or what was really graft versus host disease. So that's the beginning of transplantation. We've come a long way since then. But why should a general medical audience such as yourself be interested in transplant? Why did I get interested in transplantation? Well, I got interested in transplant because it draws on so many disciplines in medicine and in science. Pharmacology, immunology, genomics, genetics, and then the clinical disciplines of infectious disease, critical care, dermatology, GI, pulmonary, ophthalmology, rheumatology, et cetera, et cetera, et cetera. And I really have enjoyed being a clinical transplanter for these 30 plus years. And I've been able to develop very close relationships with all my colleagues from these particular disciplines. So it's been a real honor to work with them on these very ill patients. Now, what is the role of a transplantation in cellular therapy? The first goal is to replace acquired and genetic marrow defects, and to replace a source of hematopoiesis, and to do that for diseases such as aplastic anemia, immune disorders, and enzyme deficiencies. The second is to rescue marrow elements that have been destroyed by high doses of chemotherapy and radiation, sort of a rescue function, and that's done in autologous and allogeneic transplantation. And lastly, it's to remove cancer cells or other clonal elements. That's an allogeneic transplant for a malignant disease. And what we're going to go over today are these 6 areas, and these are really the challenges in transplantation. The first is who to transplant. The second, let's talk about donor availability. Third is what are the optimal conditioning for patients, the optimal chemotherapy they should get prior to transplant. Fourth, we'll talk about graft versus host disease, which is a huge issue. Fifth, immunologic recovery and infectious complications. And lastly, we'll talk about relapse. So who to transplant? The first thing we need to know is not everybody is a transplant candidate. And it's incumbent upon us as transplanters to figure out who's the appropriate person to transplant. And we use a number of different tools to help us do that. And the first is the comorbidity score. And that was developed almost 20 years ago by Mo Sorer in Seattle and his colleagues, and has been internationalized as a common screening tool to assess who might be appropriate for transplant. And so prior to transplant, we look at pulmonary function tests, liver function tests, whether someone has active infection, cardiac disorders, creatinine clearance, autoimmune disease, peptic ulcer disease, prior malignancies, obesity, and age. And all those factors go into giving us a score. And if that score is high, we know that the likelihood of transplant-related complications is going to be relatively high. And now that doesn't mean we won't transplant that patient, because we have to balance the risk of the transplant with the risk of the underlying disease. But that's an issue that comes into our factoring. The next is the disease risk index that was developed by my colleague Philippe Armand at Dana-Farber and used with the CIBMTR. And that has incorporated histology, stage of disease, and cytogenetic abnormalities to give us a sense of what the likelihoods of cure for a particular patient. And that's very important because we have to assess what the likelihood of cure is with the transplant and compare it to what survival is going to be without transplant. Two of the most interesting things that have come up recently is the issue of minimal residual disease going into transplant. We know that going into transplant, we want to prepare patients as much as possible, get their disease burden down as low as possible so that they have no active disease going into transplant. The higher the level of minimal residual disease going into transplant, the more likely as a patient will relapse after transplant. And lastly, the field of genomics has exploded in the last 20 years or more. And we use genomics very typically, particularly in myeloid malignancies, to prognosticate for patients. And I'll just go over some of these tools that we just described. This is the impact of comorbidity scores on disease outcome, and I'll have you focus on these two panels, A and C. That's the comorbidity index, and you can see the higher the comorbidity score, the higher the likelihood of transplant-related mortality, and the lower the overall survival. Here is an example of genomic profiling, and it helps us figure out who is likely to benefit from transplant. In the upper panel here, in this study from Germany about 15 years ago, you can see patients whose AML has a mutation in NPM1, but doesn't have a mutation in FLT3. And these are typical mutations that we see in leukemia patients. Patients who have a mutation in NPM1 and do not have one in FLT3 actually do not benefit at all from a transplant. So in general, we do not transplant those patients, though of course there are exceptions. And that's a good lesson to know that not all mutations confer a bad prognosis. In contrast, all the other combinations of FLT3 and NPM1 here, you can see a clear benefit for transplant in this donor versus no donor approach. In contrast, there are some patients in whom we might not also transplant because their prognosis is too poor. That's in patients who have a TP53 mutated myelodysplastic syndrome. This is work done by my colleague Coleman Lindsley here at the Farber with the CIBMTR and with the National Marrow Donor Program, looking at over 1,500 patients with myelodysplastic syndrome. What he was able to find out in looking at all the samples of patients transplanted going into transplant, those individuals who had a mutation in TP53 did terribly, with a very high relapse rate and a very low survival rate. So it gives us pause about whether we should proceed with a standard transplant in these individuals, or should we try to do something different? Should we have them on clinical trials, either not transplant them or have them on clinical trials, really focusing on relapse and on that TP53? So again, not everybody should go to transplant. Now, what about donor availability? And this is something that's changed enormously in the 30 years I've been doing transplantation. You can see that we've relied significantly on unrelated donor transplants through the National Marrow Donor Program for the past 25 years. And I'm pleased to say that we can see the survival after unrelated donor transplants, this is matched unrelated transplants, has improved steadily from 1990 through 2015. Though there's a little bit of a sawtooth there, you can see the one-year survival has improved. And that's very gratifying. That's both from improved donor selection in terms of improved HLA typing to find the right donor, as well as improvements in supportive care. So it hasn't been an overnight success. It's been iterative improvements year after year after year. Well, that's very nice. That's all well and good. But in fact, this is that is for patients who can find a fully matched donor. And finding a fully matched donor is not so easy. You can see on top there that the average family size is quite small in the United States these days, with the average number of siblings only being 1.2. That means the likelihood of having a fully matched related donor is only about 29%. And so that's why we have to turn to the unrelated donor registry. But what do we see in the registry? We find out that the distribution of HLA types is not uniform across the world, and crossing HLA barriers has been very difficult. Traditionally, mismatched transplants have been associated with a high risk of non-relapse mortality, a high risk of graft versus host disease, and poor survival. What you see displayed below you is the likelihood of finding either an 8 of 8 match in blue or a 7 of 8 match in maroon for different ethnic groups. And you can see here, way on the left, the white European patient has an over 70% chance of having an 8 of 8 matched donor, and over a 90% chance, maybe a 95% chance of having a 7 of 8 matched donor. That doesn't look anywhere near what the true population of the United States looks like. You can see with African Americans and African, that blue bar is very low, and the 7 of 8 match only gets us to about 70%. That's true for Central American and people of Caribbean extraction. Chinese, Korean, and South Asian only sit at around 40%. And you can look at the individual ethnic groups across the bottom. So we can't rely on the National Marrow Donor Program to find an 8 of 8 matched donor for all these patients. So what do we do? Well, we have to cross the HLA barriers, and we have 3 different options we can do that with. We can use umbilical cord blood. This is cord blood that's obtained from mothers who are delivering and donate their umbilical cord to an umbilical cord blood bank. We can do a mismatched unrelated donor, and you saw on the slide before, there are a number of 7 of 8 matched donors available. Or, over the past 5 to 10 years, we've been able to do what's called haploidentical or half-match related transplants. This is something that would have been unheard of 25 years ago because the mortality would have been prohibitive. That means we can access children's, parents, siblings, nephews, nieces, cousins, aunts, uncles. So today, really, over 95% of patients really have a donor. And that's a remarkable change from many years ago. So really, there is no one, virtually no one, in whom we can't find some kind of adequate donor. Well, what are the outcomes with these alternative donor transplants? Well, first for umbilical cord transplant, why that works? Well, stem cells are present in abundance in cord blood. The number of mature T cells is low, so the likelihood of graft versus host disease is pretty low. And umbilical cord blood transplant can be performed between 2, 3, or even 4 antigen mismatched donor-patient pairs with relatively low GVHD. The downside of a cord blood transplant is that engraftment and immune reconstitution traditionally has been delayed compared to traditional sources of stem cells, though most recently there have been studies on expanding cord blood units in vitro before we infuse them into patients, and they are showing a significant promise in being able to speed engraftment for these individuals. This data from Seattle compares outcomes in patients with actual minimal residual disease going into transplant and compares 3 groups of people that you can see on the top. This is not randomized. This is retrospective data from Seattle looking at cord blood, HLA-matched unrelated donors, or HLA-mismatched unrelated donors. And in this study, you can see that the actual cord blood outcomes and HLA-matched outcomes are very similar. A nice alternative for patients who don't have an HLA-matched donor. And in fact, in this black line here, you can see that the relapse rates were actually lower in cord blood transplant than they were in the HLA-matched transplants. Perhaps, we think, because of the activity in natural killer cells in that population. So you can see with that kind of positive data and the use of umbilical cord blood transplants, we see the numbers going up over time. Up, 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 but then starting to go down. Well, why is it going down? Well, that's because around 2008, data in 2011, which suggested that in fact, haploidentical transplants may be a nice option, alternative to umbilical cord blood transplants. Umbilical cord blood transplants are expensive. They have to be stored, obtained, stored, and shipped. Haploidentical transplants from family members, those family members are generally right there. And it's a much easier, less expensive proposition for us to consider. So haploidentical transplants became much more popular. Now, there are 2 ways one can do haploidentical transplants. I mentioned that they've traditionally been associated with poor engraftment and high GVHD incidence, but 2 promising approaches have emerged. One, probably 20 years ago or more, using CD34 selection, which is actually taking out T cells, taking out the cells that cause graft versus host disease. But one that's even easier than that is the use of post-transplant cyclophosphamide, which was pioneered by our colleagues at Johns Hopkins in 10 plus years ago, and has really revolutionized the way we approach transplantation, not only haploidentical transplants, but all transplants. I'll get to that in a second. This is how the theoretic mechanism of how post-transplant cyclophosphamide works. And you don't need to necessarily go through all this, but essentially, when we infuse donor cells into a patient, those haploidentical transplants identify the recipient as foreign. And those haploidentical T cells start to proliferate. This is a way of thinking about it. They proliferate, they grow, they grow, they grow, and then we come in with post-transplant cyclophosphamide, that is chemotherapy agent, that sort of cuts the knees out from under these proliferating cells and kills them, or immobilizes them at least, and allows patients to get through without graft versus host disease. So there was a lot of back and forth about whether or not cord blood transplant was superior, inferior, or the same as haploidentical transplant. So the BMT-CTN undertook what was a very difficult study. It was very difficult to get equipoise on this. There was several hundred people were randomized to get either a haploidentical transplant or a double cord umbilical transplant for a variety of diseases. This was somewhat of a heterogeneous study population. This was done with reduced intensity transplantation, so generally older patients. But what you can see here was that the progression-free survival and overall survival seemed a little bit better for the haploidentical transplant, but not all that much better. In fact, the umbilical cord blood transplants did reasonably well. The difference in terms of overall survival really was mediated by increase in non-relapse mortality in that cord blood population. Relapse rates were relatively similar. So depending on your point of view, this study either demonstrated that we can use either haploidentical transplantation or double cord blood transplant. We can do either, but outcomes might be a little bit better for that haploidentical population. There's still controversy for amongst the believers of each approach. Now, I talked earlier about mismatched unrelated donors. We can't find a matched transplant. And this is work from the NMDP and the CIBMTR, which actually did a prospective study looking at the outcomes of mismatched unrelated donors, not with the traditional approaches to graft versus host disease prevention, but using this PTCY, post-transplant cyclophosphamide platform. And what you can see here in a study that has very short follow-up, but nonetheless, actually pretty reasonable survival outcomes with these mismatched unrelated donor transplants, whether they get peripheral blood or bone marrow as their stem cell source. And this is going to be yet another opportunity, particularly for individuals from those ethnic groups who can't find a matched donor in the registry. So we'll have probably, thanks to PTCY, mismatched unrelated donor transplants, haploidentical related donor transplants, and cord blood transplants. And this is a retrospective study actually looking at, from the CIBMTR, which is the Center for International Marrow Transplant Research, looking at haploidentical transplants with PTCY compared to traditional unrelated donor transplants, where we traditionally use, say, tacrolimus and methotrexate without the PTCY. You can see the overall survivals in, this is retrospective, myeloablative and reduced intensity studies, patients, very similar. Perhaps slightly better for the unrelated donor, but really we have a number of different options for our patients, which we didn't have 30 years ago. Now, I'll say just a few words on optimal conditioning. Traditionally, you may think of transplant as a circumstance where we deliver high doses of chemotherapy or high doses of radiation followed by the infusion of the donor cells. Well, about 20 years ago, we realized we could do reduced intensity transplant. That reduced intensity transplant didn't deliver high doses of chemotherapy. It actually delivered much reduced doses of, despite those reduced doses of chemotherapy, we could achieve engraftment with this reduced. Toxicity was low and allowed a transplantation of selected older patients, even patients close to 80. My oldest patient that I've transplanted was 78, but I know some centers have transplanted patients in their early 80s. And not only those older patients, but those with medical contraindications to high-dose therapy. So really it opens up transplantation to a whole new group of people who couldn't consider transplantation years ago. Anti-tumor effect in the reduced intensity transplant is not mediated by the chemotherapy and the radiation because it's much lower doses. It's not through the conditioning chemotherapy, but it's through alloimmunity and what we call the graft versus leukemia effect. Now, graft versus host disease. Graft versus host disease is certainly something that is a significant issue with transplantation and a big challenge. And it's the big bugaboo and the thing that we worry about the most. Moderate to severe graft versus host disease increases the morbidity and mortality of transplantation, well, increases the morbidity of transplantation. However, oddly, randomized trials which have led to reductions in acute or chronic GVHD have not improved overall survival. So that doesn't quite
It seems our speaker has temporarily lost his internet connection. We'll hold on.
There he is.
Can you all hear me?
Yes.
Okay, I don't know what happened just now. We were talking about graft versus host disease, and I'll go back to where I was. The development of GVHD may prevent disease relapse after transplant. That is called GVHD.
Dr. Soiffer, you need to redisplay your slides.
Okay.
Share screen.
Okay. That is, hold on one sec. How's that?
Perfect.
And let me go into the slideshow. Okay. All right, we're back together?
Yes.
Great. So as I was saying a second ago, the pathophysiology and clinical presentations of acute and chronic graft versus host disease are somewhat different. Here are some of the risk factors for acute and chronic GVHD. They include a matched unrelated donor, a mismatched donor. Interestingly, female donors into male recipients have a higher incidence of graft versus host disease, and that's because those female donors' immune system actually can target the related minor histocompatibility antigens on the Y chromosome. If we use mobilized blood cell grafts rather than bone marrow, there's going to be more graft versus host disease, particularly chronic GVHD, because there's more memory T cells there. If we use higher dose intensity conditioning, like total body irradiation, there's going to be more acute GVHD because of cytokine release from that toxicity. And as we get older, both patients and donors, there may be some increased graft versus host disease because the aging thymus in older patients leads to less clonal deletion and more hyperimmunity. So these are factors that are associated with graft versus host disease. For acute GVHD, many of you are familiar with skin, liver, intestine, graft versus host disease. It's a very complicated scoring system. I just place it up here as a point of reference. And the treatment of acute graft versus host disease has been disappointing, to say the least, for many, many, many years. Acute graft versus host disease is treated largely with corticosteroids. They're the standard of care. We've had multiple negative phase 3 trials, randomized trials, or phase 2 randomized trials to address the treatment of steroid refractory acute graft versus host disease. Until now, until this year, when we had our first positive real trial in steroid refractory acute graft versus host disease. And this is from Rob Zeisser and colleagues, published in the New England Journal earlier this year. You can see patients on the left bar who received ruxolitinib, which is a JAK2 inhibitor, and it also inhibits JAK1, so it has anti-inflammatory capacity. Had a much higher response rate at day 28 and day 56, and a much lower likelihood of losing their response compared to best available therapy in the control arm. And you can see the failure-free survival has improved dramatically. This has been a game changer for transplantation. Ruxolitinib is now approved, FDA approved, for steroid refractory acute GVHD, and we go to it very fast in patients who are not responding to steroids. It is relatively non-toxic and has really changed how we approach graft versus host disease. Chronic GVHD is a bit of a different story. It's clinically and pathologically distinct from acute GVHD. B cells and Tregs, or regulatory T cells, may play an important role. We'll get back to Tregs in a second. The presentation is like an autoimmune disease. You can see all these autoimmune manifestations: scleroderma, cholestasis, Sicca syndrome, GI strictures, bronchiolitis obliterans, oral ulcerations. It can lead to second cancers and coagulability. Chronic graft versus host disease is poorly responsive to treatment, and extensive chronic GVHD has an extremely high mortality. This is some of the visuals of someone with sclerodermatous graft versus host disease: horrible fingernails, terrible oral changes, bronchiolitis obliterans, ocular changes, hepatic and GI issues noticed here. Now, chronic GVHD is really a very interesting phenomenon, because it has relationships to so many other diseases we see in the non-transplant world. It's characterized by allo and autoimmune T and B cell activation with a deficiency of regulatory T cells, enhanced germinal B cell reactions, production of autoantibodies resulting in inflammation, tissue injury, and fibrosis. Now, here's a rogues gallery of agents that have been used for a graft versus host disease. You can see the first, as usual, we say corticosteroids. It's the standard of care, but they have long-term toxicity. The next series of agents have all been tested in randomized trials, all of which have failed. And then we go into the blue group of agents, low-dose interleukin-2, which induces regulatory T cell expansion. I'll talk more about that in a second. Abatacept, which blocks T cell co-stimulation, and this new agent, this KDO25, which is an inhibitor of Rho-associated coil kinase 2. These have all been associated with very promising results in single-arm trials, and will need to be subjected to further study before they can be approved for treatment. Ibrutinib, which targets B cells through the Bruton tyrosine kinase, inhibits that, is now FDA approved for steroid refractory graft versus host disease. And our friend that we just talked about a second ago, ruxolitinib, there has been a report of a very positive results in a registration trial. We should see those results at ASH, and I suspect that will be approved here. What's fascinating is that so many of the drugs that have been used to treat chronic graft versus host disease are being tested actively now for COVID-induced inflammation. That includes, of course, corticosteroids, but it also includes abatacept, KDO25 is being suggested, ibrutinib, and ruxolitinib. So the pathology or the histopathology, pathophysiology of inflammation that we see in chronic graft versus host disease, we also see in some of the end organ damage associated with a COVID infection. I am going to talk about regulatory T cells for 5 minutes or so. Tregs are these CD4+, CD25+, FOXP3 cells that occupy about 5 to 10% of the circulating CD4 pool. They suppress autoreactive lymphocytes, and they control innate and adaptive immune responses and maintain peripheral tolerance. And there is this rare inherited disorder called IPEX, in which the IPEX patient will have a very low or non-functioning Treg population in their when they're born. These young adolescents develop autoimmune disease, inflammatory disease, allergies, and often have a limited lifespan because of the absence of functioning regulatory T cells. A number of other diseases in which we have, which you're familiar with, particularly in the autoimmune world, maybe type 2 cirrhosis, SLE, rheumatoid arthritis, and IBD, either have decreased numbers of regulatory T cells or decreased functioning of regulatory T cells, leading to an imbalance in inflammation and de-escalation of the immune system. Well, we identified about 15 years ago that patients who had chronic graft versus host disease had a reduction in regulatory T cells. We also recognized that interleukin-2, low doses of interleukin-2 through the binding to the high affinity IL-2 receptor, specifically on regulatory T cells, but not on inflammatory T cells. Interleukin-2 could expand regulatory T cells. And we actually went back and looked at work that we had done, that I had actually done back in around 1990, in which we actually gave low doses of interleukin-2 to patients for other reasons. And what we found in samples that we had stored in 1990 and thawed in 2005, there was a tremendous increase in regulatory T cells in those patients. In 1990, we didn't even know what Tregs were. But we went back and thawed those samples and found, in fact, that the Tregs had expanded dramatically. And well, if they could expand dramatically, maybe we can use low-dose IL-2 to treat patients with chronic graft versus host disease. My colleague John Kareth actually did just that, using very low doses of interleukin-2, 1 million units per meter squared per day, given sub-Q, found it to be safe, induced responses in 60% of patients in a variety of different organs, and saw that the IL-2 had dramatic increases in NK cells and regulatory T cells, but not conventional T cells, and increased the Treg-Tcon ratio dramatically. And pathophysiologically, we were able to show that there was an increase in proliferation of Tregs, increase in thymic generation of Tregs, and increased survival, that is, decreased apoptosis of Tregs, with minimal impact on conventional T cells. And we've been pleased to see that a number of these patients can have continued improvement with extended duration therapy. You can see in this one individual here, pictured here, and we're able to successfully decrease steroids in these patients. Now, low-dose IL-2 is being explored well beyond chronic graft-versus-host disease. It's being looked at in SLE, ulcerative colitis, vasculitis, and prevent rejection in solid organ transplant. Let's move on to immunologic recovery. We know that patients after transplant have lots of do's and don'ts about restrictions, similar to what we're all doing right now in terms of staying away from individuals who are sick, wearing masks and gloves. We know that immune recovery is delayed up to 3 months after auto-transplant and at least a year after allo-transplant. Certain transplant-associated factors like T-cell depletion, an alternative donor transplant, and the need for ongoing immune suppression will delay recovery. And vigilance against infection is critical for maintaining safety in patients. And here are just some of the infectious prophylaxis approaches that we use after transplant. These vary a little bit from place to place. But one of the biggest risks that we have sometimes is when a patient post-transplant gets admitted to the hospital and ends up with an infection or some other unrelated medical issue. Sometimes they go home without their prophylaxis. And it's always critical for a transplant patient to remain on their prophylaxis until they're out of the danger zone. So that's a thing to remember if someone gets admitted to your service. One of the big advances that we've had recently has been the introduction of a drug called letermovir. Letermovir is a novel way to approach CMV, and in this prospective randomized trial, both in high-risk and low-risk patients, that is low risk for CMV reactivation, you can see that letermovir dramatically decreased CMV reactivation in patients after works as well in solid organ transplant. And not only did it decrease CMV reactivation, but at least in this study, it appeared to decrease all-cause mortality through week 24. So that's another huge advance in terms of our approach to infectious complications after transplant. And there's that data right there. So finally, we'll finish with relapse. And relapse is really a topic in and of itself. Relapse is the most critical area as far as I'm concerned with transplant, because of course that's why we're doing the transplant. We're doing the transplant to prevent patients from relapse. So we have to make sure we're not doing anything that's going to increase their risk of relapse, and we have to figure out strategies to prevent them from relapsing. And this is a sobering slide. This comes from the CBMTR. It's a few years old, but it still applies today. If you look on this right panel here, the likelihood of dying after day 100 post-transplant, see early after transplant, there's a whole variety of reasons why patients may succumb, but after transplant, 57% of all patients who die of relapse. So that is where our challenge remains today. Now, there are many mechanisms of immune evasion. Why do transplants fail? Why does the tumor escape? Well, there can be several reasons. One, there could be new oncogenes or clonal progression, which drives proliferation of residual disease that's present. There could be impaired leukemia recognition through loss of HLA molecules or impaired antigen presentation machinery. There could be upregulation of immune checkpoints, which actually cause the T cells, the donor T cells, to be exhausted. There can be an increase in anti-inflammatory cytokines or reduction in pro-inflammatory cytokines, often related to this T cell exhaustion. So the mechanisms by our colleagues that have been recognized by our colleague Luca Vago in Milan and others really can vary from patient to patient. And one size doesn't fit all when we're trying to approach overlap. So there are a number of different potential approaches to prevent or treat relapse. I'm only going to talk briefly about 3 of them here, but this is the list of different options that we have. The first is cytotoxic chemotherapy. I'll also talk about tyrosine kinase inhibitors and end up with cellular therapy. So we talked earlier about reduced intensity transplants, how we're able to do reduced intensity transplants in older patients and patients. Some patients thought, well, maybe, some folks thought, well, maybe we can do reduced intensity transplants for everybody. And so there was a trial, a BMT-CTN trial, that's the Clinical Trials Network trial, which looked at patients with AML and myelodysplastic syndrome and randomized them to traditional high-dose or myeloablative transplants or reduced intensity conditioning. And you can see on the panel on the left, higher dose intensity was associated with more transplant-related mortality. That is a higher risk of dying of a complication of the transplant in these 18 to 65-year-old otherwise fit patients. At the same time, on the right panel, you can see that it was associated with a dramatic decrease in relapse, both for AML and myelodysplastic. And what that translated into was while no significant difference in the myelodysplastic population, in the much larger AML population, a significant reduction in survival and progression-free survival patients with AML. And an update of this study, which was published initially in 2017, now updated this year by Seattle, demonstrates that this holds up, that if we can, or at least for AML, we should be doing myeloablative transplants. More to the point, in this particular study, a fellow named Chris Horrigan from the NIH took a look at minimal residual disease through NGS screening prior to transplant. And what we can take you through on this panel here is that if a patient was NGS positive, that is, had persistent mutations going into transplant and received a RIC transplant, their relapse rate was extremely high. But if they were NGS negative, that is, no MRD, no minimal residual disease, and they received a RIC transplant, it was much better. Of course, with the MAC transplants, whether NGS positive or NGS negative, the relapse rates were low. And notice, no difference in relapse rates in the NGS positive or NGS negative patients who underwent myeloablative transplant, suggesting that dose can overcome this minimal residual disease issue. And you can see here on the right panel, actually the only inferior group were those individuals who received a reduced intensity transplant who were NGS positive. So dose does matter. Switching briefly to tyrosine kinase inhibitors, and this is really looking at targeted therapy after transplant. Traditionally, we transplanters have viewed our transplantation as the end game. This is it. Patients can't take any more therapy. This is their last chance. They can't take any more. We're not going to give them chemotherapy after transplant. But with the advent of targeted therapies, particularly these tyrosine kinase inhibitors, looking at particular mutations, we've been able to actually administer these drugs to patients safely, with a suggestion that there may be an improvement in overall outcomes due to a reduction in relapse. This is a analysis at our own institutions, Mass General and the Dana-Farber, first author Andy Brunner, looking at our studies using sorafenib, which is a multi-purpose tyrosine kinase inhibitor, but also targets FLT3 ITD, the FLT3 mutation. And you can see in this retrospective study, those individuals who received sorafenib had a much better overall survival and disease-free survival and much lower relapse rate than those individuals who didn't receive sorafenib. Well, one could say, well, that's a selected population, but the SORMAIN study, which was a sorafenib maintenance study, was performed. This was presented at ASH a little over a year ago. It's just in press in JCO, Journal of Clinical Oncology from Germany. It's a very small study. Only 83 patients were randomized to either receive sorafenib or placebo. You can see a significant, this is prospective randomized, improvement when we add sorafenib. That is a marked difference in relapse-related mortality. So This was very encouraging. It is, of course, a very small study. Right now, the BMT-CTN is following through with a prospective study of a cousin of sorafenib called gilteritinib, also targeting FLT3, to really pin this down prospectively. Lastly, and to conclude, we'll move on to cellular therapy. We know that there are many different options for cellular therapy. The one that's existed for many, many years is donor lymphocyte infusions. We actually take T cells from the donor and fuse them into the patient. And particularly for patients like with CML and with certain other diseases like low-grade lymphoma, these cells were very effective in inducing remissions. Since then, we've done a lot to modulate those donor lymphocyte infusions to try to make them more active. You can see some of the options here. We've also moved on to CAR T cells and NK cells and NK CARs, tumor-specific antigens, etc. We won't have time to go into all of this. We'll just briefly touch on DLI and CAR T cells. This is an example, the remarkable example of the GVL response in someone with actually a low-grade lymphoma who had BCL2. This is a patient, this is their BCL2 level at the time of transplant, goes down to 0. That's the gene mutation associated with non-Hodgkin's lymphoma, low grade. Patient does well for a number of years, then relapses. You can see the relapse coming. Patient gets DLI and boom, it all goes away. That is the real demonstration of the graft versus leukemia effect in action. We took a look at our own data for patients who relapsed after transplant, and we found that individuals who were able to get either DLI or a second transplant, some sort of cellular therapy after their relapse, did much better than those who didn't get any cellular therapy. And in fact, when we look more closely at these individuals, development of graft versus host disease following cellular therapy was strongly associated with improvement in survival. So that GVH and GVL, yin and yang, really still went together here. But what we'd like, instead of giving non-specific therapy that can cause inflammation throughout and cause graft versus host disease, we'd like to give specific therapy. And that's where CAR T cells come along. You've probably had talks on chimeric antigen receptor T cells, but just to refresh your memory, these are T cells that have been engineered so that they have a cellular domain, a transmembrane domain, an intracellular domain connected to a variety of different co-stimulatory agents, and the extracellular domain can target a particular antigen. What makes a cancer a good CAR T cell candidate? Well, that the tumor antigen is present on all or most of the cancer cells and is necessary for that cancer cell survival. Plus, it's important that the tumor antigen not be present on normal healthy cells, or at least not on many of them, because the immune attack on those normal healthy cells could lead to unacceptable toxicity. And that's CAR T cell therapy, and that should hopefully be able to induce anti-tumor activity without a graft versus host disease. Without going through all the data on CAR T cells, we know that there have been great successes in acute lymphoblastic leukemia, diffuse large B-cell lymphoma, and mantle cell lymphoma. There are commercial CAR T cell products that are approved for that. Multiple myeloma and follicular lymphoma both are susceptible to CAR T cells and will, I suspect, see approvals later this year or in 2021 for these indications. We're not quite there yet for AML, Hodgkin's lymphoma, T-cell lymphoma, and solid tumors, but hopefully with new technology and new targets, we'll be there soon. CAR T cells work all the time? No, they don't work all the time. They work probably only about 40 to 50% of the time are they durable responses. That could be because those CAR T cells indeed become exhausted, and we need to think of approaches to stimulate those CAR T cells, to reawaken them. And one of those approaches, this is from one of our potential trials, is with a CD19 CAR with a checkpoint inhibitor, such as is used in other immune oncology settings. Another mechanism of resistance is antigenic loss. We can find patients, say, with CD19 expressing ALL who relapse after CAR T cells. They may no longer have CD19 on their surface. So another approach to that might be using CAR T cells that express multiple receptors or have multiple receptors, so you can not just target one antigen, you can target more than one. And the ultimate goal would be to actually use CAR T cells that are off the shelf because they can be made in larger quantities. They can be ready right when you need them. It wouldn't take weeks and weeks to prepare these cells. And that is where I think the industry is going and where we hope to go in the future. Perhaps these cells will even be available and will actually eliminate the need for transplantation, though. So in my it's unbelievable to think that I have 33 years as a transplanter, which I do. And what we've seen in those 33 years is remarkable improvements, not overnight improvements, slow, steady improvements. That you saw that curve increasing like this. We've seen improved survival after transplant, improved HLA typing, an expanded donor pool, understanding who can tolerate and who can't tolerate transplant. The use of reduced toxicity conditioning for older patients, allowing expanded access to many individuals. We have new strategies now and only recently to prevent and treat graft versus host disease. We've steadily developed new antimicrobial agents to prevent and treat infection. We've been able to identify genomic risk factors for relapse and figure out who should or shouldn't be transplanted, so we're not putting patients at risk. We are starting to apply therapies targeted to prevent relapse, and particularly not only targeted therapies, but also advanced cellular therapy. But patients still die. Infection, organ toxicity, and graft versus host disease, they still succumb to relapse. And I only hope that, when my career draws to a close, we'll get closer to getting rid of that. But I'm not sure that's going to happen, but I certainly hope it's the case. All the work that we've done here, I could acknowledge many, many people, and I would. I have many, many collaborators, but I'm not going to acknowledge them. I'm going to acknowledge all the patients who submit themselves for clinical trials and those in whom we learn so much from. As some of you know, I'm a huge Yankee fan, and even though I live in Boston, I'm from New York, and this comes from Babe Ruth's 1948 autobiography. He was dying of head and neck cancer, and he participated in lots of research options. They were obviously in the early stages then, but he had the courage to know that what he was participating in would be use in the future to many people. And I'll just close with saying, what does the future bring? I don't know, but my other hero, philosopher King Yogi Berra, said it's tough to make predictions, especially about the future. So I'll leave you there, and I appreciate your attention.
Rob, this is Krishna. Dr. Weiss had to run to see a patient at the top of the hour in clinic, so he wanted to have me thank you on his behalf for what, again, he just left a couple of minutes ago, and he said it was a fantastic lecture, and I will echo his comments, and I just wanted to, I think, thank you for all your leadership on the ASTCT, the CIBMTR. Rob is actually the incoming board chair for the National Marrow Donor Program, and he's been an inspiration to many of us on top of what he's done, I think, highlighted through his talk at Harvard and the Dana-Farber. We have time for questions. There's at least one question from the chat. Well, a couple of questions from the chat from Lazarus Lakakis, who's one of our transplant docs.
Oh, yeah.
Lazarus has two questions. One, do you see a role of pegylated IL-2 plus a JAK inhibitor in combination? And then secondly, and you can take them one at a time, and I'll repeat them if you don't remember, but do you have experience with low-dose hypomethylating agents plus venetoclax in the post-transplant setting? So one
answers for both. Pegylated IL-2, we are doing a study. John Kareth is doing that with Amgen. It is a long-acting IL-2 that is not with Jakafi. It would be great to do it with Jakafi or ruxolitinib. Those combination studies need to be done. we'll be doing them over the coming years. The second question was about hypomethylating agents and venetoclax. Actually, my colleague Jacqueline Garcia is looking at that very combination. She's reported at ASH the addition of venetoclax, which is a very promising agent that's approved for AML and CLL in the conditioning regimen. And now we're going to add that to low-dose azacitidine or decitabine, actually, with venetoclax as a maintenance agent. I just consulted somebody this morning at 8:30 for that study. We really still don't know whether low-dose azacitidine or decitabine really helps. I think there's a lot of hand-waving about that, and I'm not sure how tolerable it is, and I'm not sure it actually does work, but we'll see.
The oral decitabine in IV or the regular IV?
Well, I think it's written now as the IV, but I think now the oral is around that may have to be a study amendment. We'll see.
Thank you.
So Michael Colbert has asked a question. Do you think the inability to clear niche cells is a critical cause for relapse? So, where do the cancer cells reside, and
right,
and that's
right.
a good question.
Right. So the cancer, going after leukemia stem cell, which there may be certain areas within the marrow that are privileged areas. Dave Skadden's done a lot of work on that, and we've tried to use agents to try to coax those stem cells out of those privileged areas in the stem cell in the marrow niche. I think there may be an aspect that we are not getting those cells, or Weissman thinks those cells circulate periodically, and you're able to knock them off if they're in the circulation. That may or may not be true, but there may indeed be a place where those cells hide out that we have yet to figure out how to get to.
So there aren't other questions in the chat. I see Steve is here, and Steve, like you, is wearing a tie. I don't know why, but
again, second time. This is the second time since the pandemic began that I'm wearing a tie. It's Steve.
So Steve, I don't know if you want to.
Yeah, sure. I'll ask a philosophical question. So, are there any malignancies that we're not currently transplanting that you think we should?
I don't think, in the heme malignancy world, we're transplanting lots of malignancies. We're actually moving away from transplant in certain diseases with the advent of CAR T cells and with newer agents. CLL, for instance, has been pushed further out. Myeloma is getting pushed further out. We're really left in transplantation with a series of myeloid malignancies, as well as marrow failure syndromes as the main group of people that we're benefiting. I think that introduction of cellular therapies, which we've changed it. We don't call ourselves transplanters anymore. We're transplanters and cellular therapists.
Yes, yes.
The future. So we want to make sure that we still are on both sides of that. And so I think that we may see activity in solid tumors with cellular therapy, without traditional transplantation, particularly maybe even using NK cells.
Great question. Are there other questions right now? Rob, I think it's interesting. Just to follow up on Steve's question, it's fascinating to me that some of the best results in checkpoint inhibitors have come, for example, in lung cancer, right? And it does not that we would go there. We certainly had failures of allogeneic transplant in renal cell cancer, where we thought that there might be benefit, and I think that there were some scattered failed attempts in breast cancer and other diseases. But it is interesting, because we think that the primary way that we have benefit, as you nicely highlighted, is through allogeneic graft versus tumor effects. And you can imagine, I guess, if we learn more about things like lung cancer, to figure that out. So that's fascinating. If we don't have other questions,
there's one question that I see that
Antonio Jimenez actually asked about MRD-guided post-transplant therapy. That's a great question.
Yeah, that's a very, very good question. And I've been involved talking to a number of different companies that are trying to figure out ways to actually do that. Because you know, the highest risk folks, of course, are those individuals who still have MRD, post-transplant. They have leukemia.
Yeah.
And so we need to try to go after those individuals. Chemotherapy or DLI could be a way. Perhaps we'll get a little bit more sophisticated though with targeted therapies rather than just sort of traditional chemo or traditional DLI.
Yeah, Rob, and I will add, and ironically, Lazarus asked that question earlier, but Antonio and I, and Antonio's leading this effort, are actually working with the group at WashU and others to try to think about whether we can kind of combine approaches to assess minimal residual disease and then use combinations of agents like the oral AZA, which has now been approved in combination with venetoclax.
And that study is up and going, yeah.
Correct, exactly. So I don't see other questions, but again, thank you, Rob. It was phenomenal. And really a pleasure to, I think, have you here. I wish we could have done it in person, but hopefully we'll get another chance before Jenny graduates. We have another year almost. It's looking less and less likely, but we do hope to have you back, physically before too much longer.
Well, I know you still owe me a nice dinner down there, so I do,
okay. Absolutely.
All right, okay.
All right, thank you so much.
Thank you very much. Thank you.
Thanks, everybody.
Be safe, everyone.